Welcome. Today, we're diving into a complex case involving refractory peptic ulcer disease alongside chronic diarrhea. We'll explore the clinical presentation, walk through the diagnostic workup, and reveal the final diagnosis. This journey highlights the challenges and insights that come with managing difficult gastrointestinal conditions. Let's get started. Let's start by looking at our patient's profile. Fatima Mukhtar is a 42-year-old woman experiencing several concerning symptoms. She's had black, tarry stools for 3 days, that's melena, indicating possible bleeding in the upper digestive tract. She also had a small episode of vomiting blood. For 8 months, she's dealt with persistent epigastric pain, along with chronic watery diarrhea that doesn't improve even when fasting. On top of that, she's lost 6 kilograms unintentionally and feels fatigued. This sets the stage for our case discussion. We're looking at a patient with a tough, 8-month history of severe pain right in the upper middle part of the abdomen, the epigastric area. This pain even wakes her up at night. She's tried standard treatment with proton pump inhibitors, but hasn't gotten much relief. Alongside that, she's had watery diarrhea, sometimes with fatty stools, which points to malabsorption. More recently, she experienced serious upper gastrointestinal bleeding, vomiting blood and black stools, plus early fullness and fatigue. Her medical background includes type 2 diabetes, managed with metformin, but no use of NSAIDs, smoking, or alcohol. Family history shows kidney stones in her father. Let's look at the physical examination findings. The patient appears pale and tired, a sign we can't ignore. Their vital signs show mild orthostatic hypotension, meaning their blood pressure drops when they stand up, alongside a rapid heart rate of 108 beats per minute. Dry mucous membranes suggest dehydration. The abdominal exam reveals mild tenderness in the upper middle area, but no signs of serious inflammation or liver disease. Importantly, the rectal exam finds black, tarry stool, indicating hidden blood loss. This tells us a lot about what's going on. Let's walk through the key lab results that help us understand the patient's condition. The blood count shows a low hemoglobin and a small red cell size, classic signs of iron deficiency anemia. Iron studies back this up, pointing to chronic blood loss in the gastrointestinal tract. Platelets are elevated, reacting to the anemia. Bilirubin is mildly raised, mostly the indirect type, which can happen with increased red cell breakdown. Stool tests rule out pancreatic issues and inflammatory bowel disease. Finally, liver, kidney, and clotting functions are all normal, giving us a solid baseline to work from. Let's walk through the key findings from the urgent upper endoscopy. We saw multiple ulcers just beyond the duodenum, with an actively bleeding vessel that was successfully clipped, stopping the bleeding right then and there. The stomach lining showed thickened folds, but testing for Helicobacter pylori came back negative. Next, the endoscopic ultrasound with biopsy revealed a well-differentiated neuroendocrine tumor in the duodenum. Finally, nuclear imaging confirmed this tumor's location, showing no signs it had spread elsewhere. These findings together give us a clear picture of the condition we're managing. Let's look at some key tests that help us diagnose gastrinoma. First, fasting serum gastrin levels. When these are over 1,500, that's a big red flag, especially if the patient isn't on acid blockers. Normally, gastrin stays below 100. Next, gastric pH. A low pH around 1.2 tells us there's true acid hypersecretion going on. That's important because it rules out other causes where acid is low. Finally, the secretin stimulation test. A positive result shows a paradoxical rise in gastrin, confirming the tumor's autonomous secretion. These tests together paint a clear clinical picture. Here, we're looking at a localized duodenal gastrinoma, a well-differentiated neuroendocrine tumor that causes Zollinger-Ellison syndrome, or ZES. This tumor leads to several serious complications. Multiple ulcers form just beyond the duodenal bulb, causing acute upper GI bleeding, which we managed with clipping. The patient also faces severe secretory diarrhea, putting them at risk for malabsorption. Chronic blood loss leads to microcytic iron deficiency anemia, and overall, there's unintentional weight loss and fatigue. This slide sums up the final diagnosis. Let's start by understanding why Zollinger-Ellison syndrome is important here. We're dealing with refractory peptic ulcers, those stubborn ulcers that just don't respond to usual treatments like proton pump inhibitors. Patients often have epigastric pain that wakes them at night, and multiple ulcers beyond the stomach's bulb point us toward this diagnosis. Then there's secretory diarrhea. It happens because a massive acid load floods the small intestine, messing with enzyme activity and fat absorption, causing persistent symptoms even when fasting. For tumor localization, advanced imaging like endoscopic ultrasound and specialized PET scans pinpointed the tumor right in the duodenal wall, with no spread elsewhere. This clinical reasoning ties the symptoms and findings together. Now let's look at the family history. The patient's father has had recurrent kidney stones. That raises a red flag for familial hyperparathyroidism, which can be part of a bigger picture. Gastrinomas, like the one here, often show up in multiple endocrine neoplasia type 1, or MEN1, a syndrome involving the parathyroid, pituitary, and pancreatic or duodenal neuroendocrine tumors. Right now, the patient's calcium and parathyroid hormone levels are normal, so there's no clear biochemical evidence of MEN1. But because gastrinoma can be the first sign, a formal genetic evaluation is recommended. This calls for a multidisciplinary approach to consider all possibilities. When we see multiple peptic ulcers that don't respond to typical treatments, especially beyond the stomach and with ongoing diarrhea, we need to think about Zollinger-Ellison syndrome, or ZES. Diagnosis hinges on a specific triad: very high fasting gastrin levels, low gastric pH, and a positive secretin stimulation test. For locating tumors, Ga68DOTATAT PET-CT is the best tool. And don't forget to check family history for signs of